Good morning everybody and welcome to another Insight APSAD webinar. This is sadly the final one for 2019, so thank you for joining us for the last one of the year. To start with, I'd like to acknowledge the traditional owners and custodians of the land on which we meet today and pay my respects to elders past, present and emerging. And I'd like to extend that welcome and respect to any Aboriginal or Torres Strait Islanders that might be joining us in the room or indeed on webinar land. So thank you and welcome. I'm pleased today to talk about a topic that I used to work in. Prior to coming to Insight a few years ago, I was a dual diagnosis coordinator, and it's certainly an area of clinical practice which I think many people both in mental health and AOD struggle with. So today it's going to give me great pleasure to introduce Erin Madden. She's a research officer from the Matilda Centre coming out of the University of Sydney, and she's going to talk to us about some guidelines which will hopefully help you to upskill in this area and help you in your clinical practice. So please welcome Erin Madden.
Thanks so much, Jim. Hi, everybody. Thanks for joining me today. So as Jim mentioned, my name's Erin. I'm a research officer at the Matilda Centre, and I'm working on the disseminating the second edition of the National Comorbidity Guidelines. So what I'm going to cover today is talk about those guidelines and the resources that accompany them and how they might be helpful in managing co-occurring mental health and substance use conditions. So in terms of what I'll cover today, so I'll start by giving an introduction to comorbidity, which will provide a bit of context for the rest of the talk. I'll then cover the holistic healthcare approach, which underpins our guidelines. Following this, I'll go over identifying comorbidity, touching briefly on screening, assessment and case formulation. I'll then discuss current approaches to managing and treating comorbidity, followed by an overview of coordinated care. Following this, I'll give a brief overview of the guidelines project itself, followed by a demonstration of the National Comorbidity Guidelines website and online training program. And I'll close by walking you through the preliminary results of an evaluation study we did on this training program. So firstly, what do we know about comorbidity? So not intending to tell you things you already know, but just to walk you through our understanding of comorbidity and how we've applied that in approaching developing the guidelines, just so you know where we're coming from. So before doing that, just want to clarify what I mean by the term comorbidity. So broadly defined, comorbidity can refer to the co-occurrence, and that might be lifetime or current, of two or more disorders. But the focus here today is on the co-occurrence of an AOD use disorder with one or more mental health, with one or more mental health disorders or conditions. So there are, of course, other types of comorbidity that might include other AOD use disorders, including tobacco, physical health conditions like cirrhosis, hepatitis, heart disease, and diabetes, intellectual and learning disabilities, cognitive impairment, and chronic pain. So the co-occurrence of one or more AOD use disorders with one or more mental health conditions is often referred to as dual diagnosis, as Jim mentioned, but there are multiple types of co-occurring conditions that clients might present with, which might range in severity, so there might be more than two. So in terms of what we know about comorbidity, we know it's extremely common. So mental health and substance use are two of Australia's most common and burdensome health conditions, and they affect approximately 1 in 5 Australian adults every year, and they frequently co-occur. So it's estimated that, about 1 in 3 Australians with a substance use disorder will meet criteria for at least one other mental disorder, but this can be as high as 75% amongst those seeking treatment. So comorbidity's always been a feature among patients with AOD conditions, and those of you who are clinicians will have likely seen all manner of comorbidity in your clients. But in terms of why comorbidity has received all this increased attention, comorbidity was first able to be measured at a population level in North America in the 1980s and reported in the literature as through the epidemiologic catchment area studies in the 1980s. So several structured diagnostic interviews were developed from that, which greatly facilitated large-scale nationally representative population surveys. So in terms of our own nationally representative surveys, the National Survey of Mental Health and Wellbeing, that was conducted in 1997 and 2007 by the Australian Bureau of Statistics, and both of these surveys identified large rates of comorbidity and within classes of disorders. So the 2007 survey sampled 8,841 adults aged 16 to 85 years of age. So the figure on the screen illustrates the prevalence rates of disorders in the general adult population for 2007. So approximately 45% of people had any mental disorder at some point in their lifetime, and 20% of people had an active disorder in the past 12 months. So this figure also shows how that 12-month prevalence rate was identified, that is, as a proportion of those with a lifetime disorder who had an active disorder in the past 12 months. So in terms of how many people in the Australian general population experience comorbidity, findings from the most recent National Survey of Mental Health and Wellbeing, which was in 2007, showed that affective and anxiety disorders are the most common comorbidity experienced by both males and females. So here males are on the left and females are on the right. This was followed by AOD use, comorbid with anxiety disorders, again for both sexes. So approximately 35% of people with a substance use disorder have at least one co-occurring affective or anxiety disorder, representing about 300,000 Australian adults. This also tends to be higher rates of substance use and mental health conditions among specific populations in comparison to the general population, so for example amongst homeless people. So research has highlighted the complex AOD use histories and extensive polydrug use in homeless communities, with one study finding that 42% of participants reported severe levels of depression and 57% screened positive for current PTSD. More than 1/3 had received a diagnosis of schizophrenia or other psychotic disorder. So rates of AOD use and mental health disorders are also elevated in prison populations. So the most recent Mental Health of Prison Entrants in Australia report, conducted by the Australian Institute of Health and Welfare, found that 1/3 of prison entrants reported having received a formal diagnosis, formal mental health or substance use diagnosis, which is 2.5 times higher than the general population. So 16% were taking medication for their mental health disorder, and 14% were experiencing very high levels of psychological distress. So in comparison to other prison entrants, those with these poor mental health conditions had extensive prison histories, they had poor education, they had higher rates of unemployment and substance use. So there were also higher rates of risky alcohol, illicit drug use, and smoking than the general population, particularly among those with high levels of psychological distress. And of course, these are just some of the different population groups who experience higher rates of substance use and mental health conditions, and there are many others. So in terms of the most common mental health conditions we see co-occurring with substance use, these are about the same as what you'd find in the general population, so anxiety and depression, PTSD and personality disorders, but we also see high rates of bipolar disorder, psychosis, ADHD, OCD, and eating disorders. And the fact that these disorders do co-occur is problematic, as once they're both established, they serve to maintain and exacerbate each other. So there are also many people who might experience symptoms of mental health conditions but might not meet criteria for a diagnosis. And despite this, they have their lives significantly disrupted by these symptoms of mental health disorders, but because they don't meet this diagnostic criteria, they might fly under the radar of some services. So the prevalence of mental health disorders may vary between substances, but there has been little research conducted comparing the rates of mental disorders across different types of AOD use disorders, so there's not much information available to help guide health practitioners in this sense. Substance use amongst those with mental disorders tends to mirror general population trends in terms of availability and fashion. So in terms of what causes comorbidity or why it occurs, there are several possible ways it might occur. So in some cases, AOD use disorder can come about as a result of repeated AOD use to relieve or cope with mental health symptoms. So this is what's referred to as the self-medication hypothesis, in that substances are used in an attempt to cope with mental health symptoms. In these circumstances, mental health conditions may become more apparent after the AOD use has ceased. Alternatively, AOD intoxication and withdrawal can induce a variety of mental health symptoms and disorders, such as depression, bipolar, anxiety, obsessive-compulsive, and psychotic disorders. So in the majority of cases, these effects subside and eventually disappear with abstinence. However, for some people, symptoms may continue even after they've stopped drinking or using substances. So if one condition has an effect on an intermediary factor, which then increases the likelihood of developing a second condition, an indirect causal relationship exists. So for example, research has shown that early onset AOD reduces the likelihood of finishing high school, entering tertiary education, and completing tertiary education. So poor education may lead to difficulties in later life, such as employment, which may lead to other problems such as depression. But the reverse is also possible, where a depressive disorder may initially make it more difficult to complete these work and study commitments, which then may in turn lead to difficulties finding employment, which increases the risk of AOD use itself. So the co-occurrence of AOD and mental health conditions can also come about due to shared biological, psychological, social, or environmental risk factors. So in other words, the factors that increase the risk of a person developing one condition may increase the likelihood they'll develop another. So for example, AOD and mental health conditions have been associated with lower socioeconomic status, cognitive impairment, the presence of conduct disorder in childhood, and antisocial personality disorder, or ASPD. It is also possible that genetics plays a role. So the challenge here is the relationship of mutual influence that exists between these conditions. So once they've both been established, regardless of how they came about, once they're both present, it's likely they will both, as I mentioned, maintain and exacerbate the other. So on screen here is an example of this relationship of mutual influence. So a person may engage in AOD use to relieve the symptoms of their anxiety, but research indicates that repeated AOD use can actually increase anxiety. It's also possible that the relationship can change over time, so depression may trigger AOD use on some occasions, but be the result of AOD use in others. But the question becomes, when do we need to be concerned about a person's use? Do we need to respond to any use, or is it only when a person is dependent on substances that we need to think about intervention? So not everyone who uses will become dependent. Evidence indicates that the most addictive substance is tobacco, with up to 2/3 of people going on to develop dependence after first using it. This is followed by stimulants, opioids, sedatives, alcohol, and cannabis, with an estimated 1/3 of users developing dependence or a substance use disorder. So it is important to note that while many drink or use at high levels without meeting criteria for a disorder, they may nonetheless be at risk of harm. Sorry, just go back there. So I won't talk in detail about the characteristics of people who are at risk of becoming dependent, but conditional probability estimates that about 46% of stimulant users would develop a stimulant use disorder, 45% of opioid users would develop an opioid use disorder, 39% of sedative users would develop a sedative use disorder, 35% of alcohol users would develop an alcohol use disorder, and the figure hasn't come through on the slide, but it's 32% of cannabis users would develop cannabis use disorder. So in terms of who may be more likely to develop a use disorder, assumptions about what a person who uses might look like can be harmful to identification and treatment. So we might think from looking at the screen that we know who is at greater risk. However, statistically speaking, number 5, the young man in the suit, is more likely to have a substance use disorder. But having said that, it's also important to remember that anybody can develop a substance use disorder, and these types of assumptions can sometimes lead to a lack of recognition or screening for substance use disorders. So in general, few people who experience these conditions access treatment, in part because when they have difficulty accessing the services, and they also are faced with quite a bit of stigma when they do try and access treatment. So it's estimated that 1 in 10 people with a substance use disorder alone seek treatment. However, when you couple this with mood and anxiety, this rate increases to 70 to 80%. So this indicates that mental health or the complexities that accompany comorbidity may be driving people into treatment. So evidence tells us that the median delay among people with alcohol use disorders who eventually make treatment contact in Australia is 18 years. So among those with any mental disorder in the previous 12 months, the most common way of accessing treatment was visits to community-based providers, mainly things like GPs, psychologists, and to a lesser extent psychiatrists. Mental health hospitalizations were relatively uncommon. So not only do people with comorbidity experience symptoms of their mental health and substance use disorders, but they also have more complex presentations which can complicate treatment and recovery. So for example, they're at a higher risk of having complex trauma histories, poorer physical and mental health, poorer social, occupational and interpersonal functioning, more severe and extensive drug use histories, increased risk of self-harm and suicide, and a reduced life expectancy overall. So this means that there's a vast number of issues that need to be addressed, and they needs to be addressed within a holistic framework. So research has shown that people with mental or substance use disorders die an astonishingly 20 to 30 years earlier than the general population and spend the last 10 years of their life living with disabling chronic illnesses. I'll just wait until that gentleman's taken a photo. All good? So comorbid mental health and alcohol or other drug disorders have been identified by the Mental Health Commission as one of Australia's most significant challenges in health. But it's not all doom and gloom, so comorbidity is not an insurmountable barrier to treating people with AOD use disorders, and research has shown that clients with these comorbid mental health disorders can benefit just as much as those without from the usual AOD treatment. So, although establishing the order of onset between conditions can be useful for understanding the relationship between these conditions, once these both have been established, it is most likely that the relationship between them is one of mutual influence, rather than being a clear causal pathway, and irrespective of what order which condition came first, the strategies to manage them are the same. So just to sum up what I've covered so far before I move on, comorbidity is really common, it complicates treatment and recovery, there's a relationship of mutual influence, irrespective of which disorder came first, management strategies are the same, and there is an unmet need for treatment and the wait to access treatment is long. So now I'll talk a little bit about the holistic healthcare approach, which as I mentioned underpins our guidelines. So people with comorbidity are at a particular risk of developing cardiovascular disease, and this is due to high rates of smoking, being overweight or experiencing obesity, a poorer diet, physical inactivity, high alcohol consumption, and the use of some antipsychotic medications. So research has highlighted the need for interventions that focus on overall well-being, including reducing smoking, improving dietary habits, increasing physical activity, and improving sleeping patterns. And because physical and mental health are so fundamentally entwined, focusing on overall well-being by providing a holistic response and taking steps to manage people's physical and mental health is likely to lead to these improved outcomes. So strategies to help overcome these barriers in terms of what gets employed, some service providers are reluctant to address multiple health behaviours because of the belief that making too many lifestyle changes will undermine a person's recovery from substance use. But although this is not particularly evident in relation to smoking cessation, although this is particularly evident in relation to smoking cessation, this view is not supported by the evidence, which indicates that the use of multiple health behavioural changes is effective. So strategies to assist to overcome the barriers associated with behavioural change might include helping clients minimise their physiological symptoms of nicotine withdrawal with nicotine replacement therapy, just being mindful of different doses, the potential for NRT to interact with the metabolism of different medications, and the contraindications for NRT. Workers might use the Australian Dietary Guidelines to help clients develop healthy eating patterns or food spending structure, which links household budgets to food groups. The food and activity diary and devices to track physical activities, such as pedometers, heart rate monitors, and using fitness trackers as motivational tools. And lastly, encouraging healthy sleeping habits. So the broad focus of a holistic approach is centred on delivering the right services to the right person at the right time, which means healthcare workers' roles might include involving multiple services in a coordinated client-centred approach. So this approach also means that healthcare workers might need to not only address the physical and mental well-being of their clients, but also involve and partner with other available services to deliver this complete individualised care. So I'll talk now a little bit about identifying comorbidity. So detection, despite high rates of mental health conditions among AOD services, the detection and treatment of these coexisting problems are usually pretty low. That's why it's really important to screen all clients systematically and assess for such problems. So awareness of co-occurring problems will assist the management of more complex presentations and treatment planning. And of course, to identify problems accurately, there may be a need to involve professionals that are trained and experienced in differential diagnosis. Screening can help identify the potential need for formal psychiatric assessment as well. And multiple assessments conducted throughout treatment can take into account how these symptoms change over time and be fed back into the treatment process. So health workers are also encouraged to become familiar with the DSM-5, in particular its uses, implications and recommendations regarding differential diagnosis, or which symptoms are attributable to which disorders. And it can be useful to be aware of different signs of disorders, meaning what is objectively visible about the client, such as sweating, as well as symptoms of the disorders, which is what the client might describe to you, including sadness. So 3 elements that can be really helpful in identifying comorbidity that I'll briefly touch on today are screening, assessment, and case formulation. So screening is the process of identifying possible cases of co-occurring mental health conditions. Screening is not a diagnostic process. It can't establish whether a disorder does actually exist, but it can be useful in identifying symptoms typical of a disorder and highlighting the need for further assessment. So ideally, screening should be conducted after a 2 to 4 week stabilisation period. However, in practice, it can be incredibly difficult in treatment settings for such periods to occur. As such, workers need to be aware of the potential for false positives, which can occur if the client is screened during periods of acute intoxication or withdrawal. So to avoid the possibility of misdiagnosis or false positives, multiple assessments should be conducted over time. So some instruments that AOD workers might find useful include the Camberwell Assessment of Need Short Appraisal Schedule, or CANSAS, the Kessler Psychological Distress Scale, or the K10, and the Depression and Anxiety Stress Scale, or DAS. So CANSAS P, K10 and DAS 21 and their scorers, as well as additional screening tools, cover a broad range of conditions, and they can all be accessed in the Comorbidity Guidelines. So another resource which workers may find useful is Mark Deedy's 2009 review of screening and assessment tools for use in AOD settings, which includes a comprehensive overview of all the screening and assessment measures where these can be accessed, whether there's a cost involved in accessing their use, details of their reliability and validity in AOD settings, as well as their strengths and limitations. So it's free to download from the NADA website, and I've put the hyperlink on the slide, which will be distributed afterwards. So assessment involves a detailed investigation of a person's mental health, and there should be an ongoing process to take into account changes in mental health symptoms throughout treatment. So assessment also informs case formulation and treatment planning. So the depth of assessment depends on the needs of the client at the time. So for example, the amount of information needed for a brief intervention is going to be much less than the amount of information you might need for more extensive treatment. So assessment components might include presenting issues, AOD use history, medical history, risk assessment, psychiatric history, trauma history, mental state, readiness to change, family history, criminal history, current situation, strengths and weaknesses, and personal history, as well as the source of referral. So the process of case formulation involves gathering information regarding factors that may be relevant to treatment planning and formulating a hypothesis on how these factors fit together to form the current presentation of the client's symptoms. So after developing a case formulation, the health worker might be aware of what problems exist, how they developed, how they're maintained, as well as aspects of the client's presentation, current situation, and the interaction between these different factors and problems. So this information is the first step to devising and then later revising the client's treatment plan. So the primary goal of any service should be to improve client and patient's quality of life, but of course, in order to do so effectively, healthcare workers need to take into account these broad range of issues that the client may present with. So in addition to these dimensions, consideration should be given to the client's age, sex, sexual orientation, ethnicity, spirituality, socioeconomic status, and cognitive abilities. It's also important to differentiate between substance-induced and independent mental health disorders. So symptoms of mood anxiety and psychotic disorders may all be induced as a result of AOD use or withdrawal. So for example, alcohol use and withdrawal can induce symptoms of depression or anxiety. Manic symptoms can be induced by intoxication with stimulants, steroids, or hallucinogens, and psychotic symptoms can be induced by withdrawal from alcohol or intoxication with amphetamines, cocaine, cannabis, or LSD. So to find out whether a disorder is substance use induced or independent, we might be able to ask whether the client has any current mental health symptoms such as depression, anxiety or psychosis, whether they have experienced these in the past, and whether they've ever been diagnosed formally with a mental health disorder. If the client has experienced mental health symptoms or has been diagnosed with a mental health disorder, you might ask about the timing of these symptoms. So, when did they start? Did they start prior to AOD use? Do they only occur when the person is intoxicated or withdrawing? Have the symptoms continued even after a period of abstinence, so about a month? Do the symptoms change when the client stops using substances? So do they get better? Do they get worse? Do they stay the same? Is there a family history of the particular mental health condition? So if symptoms occur only in the context of intoxication or withdrawal, it's likely that they are substance-induced and will resolve within a period of abstinence without the need for any direct intervention. Having said that, however, it's still important to manage these symptoms to prevent the client from relapsing. If mental health symptoms started before the onset of substance use, if symptoms persist even during periods of abstinence, or if there is a family history of a particular mental health condition, the client may have an independent mental health condition. So as you can see, it can be really difficult to distinguish substance use psychosis from other psychotic disorders, and if a person is experiencing symptoms of psychosis, it may not be possible to elicit information that will help address the onset of symptoms, family history, AOD use, and so on. But some substance-induced symptoms may help differentiate between substance-induced psychosis and independent psychotic disorders. So substance use symptoms tend to appear quite quickly and usually last a shorter time than until the effects of the drug wear off, although they can, for some people, last longer. And visual hallucinations are more common in substance withdrawal and intoxication than in primary psychotic disorders. So some of the common symptoms of low-level crystal methamphetamine-induced psychosis might include suspiciousness, guardedness, and hypervigilance. So this might be such as constantly being on the lookout for threats, overvalued ideas, which might be ordinary events which have special meaning or significance, illusions or misreading the environment, so a shadow looking like a person walking into a room, or a random sound sounding like a police siren. Erratic behaviour, which might seem like paranoid ideas, like accusing others of having wronged the person or arguing with bystanders for no apparent reason. So stimulant psychosis is more commonly associated with more tactile hallucinations or ice bugs, and people experiencing stimulant psychosis may be more agitated, energetic, and physically strong, and more challenging to control in a safe environment. However, they may be more difficult to calm with sedating or psychiatric medication than independent psychosis. So far, just to give a quick summary before I move on, comorbidity is common, it complicates treatment and recovery, there's a relationship of mutual influence, consider a range of factors, not only AOD and mental health issues in case formulation. Full assessment should ideally occur after a period of abstinence, or at least when the client is not withdrawing or intoxicated. Conduct multiple assessments throughout treatment as symptoms may change over time, and provide assessment feedback, which I'll just add in here, in a positive, easily understood way to the client. So now in terms of the evidence of managing and treating comorbidity. So just before I talk about that, I want to quickly touch on the models of care. In terms of approaches to comorbidity, there are four main models, which are sequential treatment, parallel treatment, integrated treatment, and stepped care. So I won't go into detail, but it's worth noting that there has been a lot of discussion of models of care for people with comorbid disorders, but there's actually very little research available to determine which models may suit which comorbidities. So AOD workers may need to make pragmatic decisions as to which model is most appropriate for their individual clients. So having said that, however, the idea of integrated treatment for two disorders has considerable intuitive appeal. It presents a number of advantages over other treatment approaches. This includes the fact that there's a single point of contact, so the client doesn't fall through the gaps. There are common objectives, treatment's pretty internally consistent. The relationship between the AOD use and mental health conditions can be explored, and communication problems between agencies doesn't interfere with treatment. So, although research is limited in this case, there is some emerging evidence to suggest that these integrated treatments may be superior to parallel or sequential treatments in terms of improving outcomes for clients. So there's a distinction between the management and treatment of comorbidity that we make in the guidelines. So the goal of management of mental health conditions is to allow AOD treatment to continue with minimal disruption or dropout. So management strategies described in the guidelines are done so to provide short-term relief and control over symptoms, and they're basically an interim measure during AOD treatment until full treatment of co-occurring conditions is possible. So guidelines also provide do's and don'ts and more practical strategies for managing these commonly co-occurring conditions or symptoms. There we go. So there are a range of options for managing and treating comorbidity, and not all treatments will suit each client. So although AOD workers are probably pretty familiar with the more traditional psychological and pharmacological approaches, these have limited evidence for comorbidity. In the absence of specific research, however, it is generally recommended to use the most effective treatments for each mental disorder. So both psychological and pharmacological interventions have been found to have some benefit. So when pharmacotherapy is used, it should always be accompanied by these supportive psychological interventions, with workers aware of the potential interactions between medications and other substances. So in addition to these approaches, a new addition to the second version of the guidelines is a discussion of e-health interventions, physical activity, and complementary and alternative therapies. So for most disorders, exercise and physical health interventions have also shown to have some benefit. So for example, ADHD and schizophrenia, bipolar, depression, anxiety, OCD, PTSD and eating disorders, although more research on comorbid disorders together is needed. So I won't go into detail, but the second edition of the guidelines discusses the evidence regarding the treatment of disorders like ADHD, psychosis, bipolar, depression, anxiety, so generalized anxiety disorder, panic disorder, and social anxiety disorder, obsessive compulsive disorder, post-traumatic stress disorder, eating disorders, and personality disorders. In addition, management of symptoms that may cross various disorders is discussed. Things like anger, grief, and loss. Strategies to manage these are also provided. But regardless of treatment method, a coordinated care approach is crucial, so I'll just touch on this now. So one of the biggest risks in referring clients to external services is the potential for them to fall through the gaps and disappear from treatment altogether, and likely a lot of people are familiar with this process happening. So you're probably familiar with this image, which represents how clinical services have traditionally adopted a siloed approach in which mental and substance use disorders are treated separately, which limits the treatment effectiveness. So as a result of this, people may be bounced around between mental health and AOD services with little continuity or coordination of care, and they fall between the cracks. So to give an example of what this might look like, one possible scenario might be someone starting with a referral from their GP or for an AOD counsellor, but when they get there, the counsellor refers them to a psychologist instead. So they re-enter the roundabout only to be told by the psychologist that a psychiatrist is actually needed. However, when they try to access this psychiatrist, their calls aren't returned or it's full and they face a closed door. So this is one example of what can happen in practice, and there are a lot of services people need to navigate their way through. And people with comorbidity often have difficulty navigating their way through these services, which can be, as you can see, really difficult to access because they've got multiple entry points, multiple options of treatment pathways, agencies, and healthcare providers. So often by the time someone with these disorders is ready to access treatment, they've been experiencing symptoms for a number of years, and it can then be really challenging to be bounced around and referred between services. So therefore, it's critical for care coordination and the referral process to focus on linking clients in with services as smoothly as possible. So here the development of more formal links between services regarding consultation, referral pathways, and collaboration can really help this process. So coordinated care increases the likelihood that clients will receive specialised assistance where it's needed and facilitates client engagement in treatment. Evidence has linked coordinated care with improved treatment outcomes, such as prolonged client retention, increased treatment satisfaction, improved quality of life, and increased use of community-based services. In terms of an AOD worker's role in coordinated care, although coordinated care is facilitated by an identified coordinator or case manager, they're not expected to provide all these necessary services themselves, but instead refer to and manage the engagement of these appropriate services. And the challenge is then on this active engagement of multiple services and service providers with a mixture of professional and non-professional support. AOD workers are in primary positions to coordinate care and incorporate many services that reflect the particular needs of clients to deliver the best quality care. But the question then becomes, how can we support these workers to help build capacity to provide this care? And this is where our National Comorbidity Guidelines entered the picture. So just to give an overview, in 2007, the Australian Government Department of Health and Ageing funded researchers at the National Drug and Alcohol Research Centre to develop the first edition of the national guidelines, or as they're more formally known, the Guidelines on the Management of Co-occurring Alcohol and Other Drug and Mental Health Conditions in Alcohol and Other Drug Treatment Settings. And this was under the Comorbidity Initiative. So since their publication in 2009, almost 16,000 electronic copies have been disseminated and training was rolled out nationally to accompany the guidelines in 2010. They also became a recommended text for students studying courses in alcohol, other drugs and mental health. So although they were a really popular and successful clinical resource, since they were first published in 2009, the research relating to the management and treatment of comorbidity has grown considerably. So we were funded by the Department of Health to update, revise and disseminate the guidelines so they would reflect the most available evidence. There we go. And just to let you know, in December 2018, the National Drug and Alcohol Centre for Research Excellence in Mental Health and Substance Use, or CREMS, moved from NDARC over to the University of Sydney to start the Matilda Centre, which is where I've come from today. And when we moved, the guidelines resources moved with us. So, the development of the second edition of the guidelines was based on a synthesis of the best available evidence, identified by comprehensive literature reviews, feedback from a multidisciplinary panel of experts, so this involved consumers, carers, academics, as well as clinicians, and feedback from other interested stakeholders at a discussion forum. So the expert panel and discussion forum also provided feedback about preferred mediums for disseminating and translating the guidelines. And the second edition were officially launched in 2016, and they aim to increase the knowledge and awareness of comorbid mental health conditions in AOD treatment settings, improve the competence and skills of AOD workers, and increase the uptake of evidence-based care. So in terms of what's in the guidelines, Part A provides context, which I've briefly touched on, about prevalence, why comorbidity is important, and then it provides the guiding principles of working with these clients, which really forms the basis of the approach to addressing comorbidity, as well as touching on the different disorders and their classification. So Part B covers responding to comorbidity, and it includes holistic healthcare, identifying comorbidity, risk assessments, care coordination, approaches to comorbidity, managing and treating specific disorders, as well as worker self-care. So we provide an overview of the different approaches that are available in the treatment of comorbid AOD use and mental health disorders. Healthcare workers, as I mentioned, pretty likely familiar with psychological and pharmacological approaches, but as I mentioned before, in addition is the new part about the e-health interventions, physical activity, and complementary and alternative therapies. So I briefly touched on this before. We cover a wide range of disorders, and in addition, management techniques for symptoms that may cross multiple disorders. So lastly, Part C looks at comorbidity in specific population groups such as Indigenous Australians, culturally and linguistically diverse groups, gay, lesbian, bisexual, transgendered and intersex individuals, rural and remote communities, homeless persons, women, men, coerced clients, so when someone's brought into care against their will, young people and older people. So I'll now walk you through our National Comorbidity Guidelines resources, which includes the website and the online training program. So this is a really great place to learn how to put all the things I've been discussing today into practice, and everyone in the room's got flyers on their chairs to access that online. So with support from the Australian Government Department of Health, the Guidelines project was extended after the publication of the hard copy to include a dissemination strategy. So this was to aid the uptake of the guidelines into practice. So the dissemination and translation strategy was based on consultations with clinicians and AOD workers, consumers, and people with lived experience, carers, clinicians, and involves a three-pronged approach via hard copy distribution, building a website to host the guidelines and their resources, as well as the translation of the guidelines into this free online training program. So the initial hard copy distribution included all AOD services Australia-wide, specifically targeting people working in the field, as well as universities and TAFEs that were providing courses in mental health and alcohol and other drugs. So since their publication in August 2016, we've sent more than 6,300 hard copies across Australia. We continue to get about 100 copies ordered through our website a month, that's on average. In addition, more than 7,800 electronic copies have been downloaded. And just to let you know, we are currently out of stock of the hard copies, but the PDFs are still available, which is great news. They're obviously very well received. But PDFs are still available to download for free via our website. So you can also keep in touch to be notified if hard copies become available via the email that I'll have at the end of the presentation. So as for the website, this was launched in November 2017 and is designed to be pretty simple and therefore accessible. It hosts the guidelines content, an online training program. It also includes a download section where you can build your own guidelines. You can mix and match the sections that I've talked about today that are most helpful or relevant to you, and then download them as a unique kind of guideline for your own service or yourself. You can also access all the resources such as screening tools, the K10, the DAS that I mentioned before, assessments and worksheets, which are all available for download. And last but definitely not least, our online training program. So this was based on the guidelines. It's free. It takes approximately 10 hours to complete online. So ultimately, the training program aims to increase the uptake of the guidelines and facilitate their translation into practice. And it does this through 4 key aims. So firstly, increasing the knowledge and awareness of these co-occurring mental health conditions among the AOD workforce, improving the confidence and skills of AOD workers to manage co-occurring mental health conditions, increase the uptake of evidence-based care, and improve outcomes for people with co-occurring AOD and mental health conditions. And we chose the medium of online training because it has the capacity to overcome many barriers of traditional training models, which makes it a far more sustainable method of providing training. So online training ensures the program is consistent, it's up to date, it's more feasible with a wider reach, and it can remain up to date more easily. So as users have control over their own training programs, it also reduces information overload, and it has a shorter delivery cycle time, meaning the gap between learning the content and putting it into practice is lessened. So the training program was developed in line with e-learning principles, which is to say that it's interactive, it's got a clear rationale for the overall course, as well as clear objectives for each individual module. So e-learning is most effective when there's strong job-relevant content based on the most up-to-date evidence. The program's based on a multimedia approach. As we know, information is remembered better when it's presented in different modes, like animations, narrations, videos, and case studies. We also wanted to avoid a Las Vegas approach, which is when there's just too much information and stimuli. It causes a cognitive overload and information's just not retained. So you've probably seen plenty of websites like this. We also want to make sure that graphics support the text, so if they don't serve a purpose, they are distracting. For example, the photo on this slide here actually has nothing to do with what I'm talking about, but it probably grabbed your attention for a second or two and distracted you from what I was talking about while you tried to figure out what it was doing there. So we want to make sure that all information in the program is actually relevant to the training program itself. And finally, research indicates that an important aspect of e-learning is assessment. So for a person to retain information, they must be able to retrieve it. So this is the homepage of our website with the URL at the top there for anyone wanting to access it. From here, you can access an online version of the guidelines. You can read more about the online training program or register for training. And this is where you can access those tools such as client worksheets, screening tools, assessments, and links to external resources. There's also a direct link at the top there for to register for online training. So this is really quick. It's just a form with only 5 fields to fill out. You'll then be immediately receive an activation code via email, and once this is verified, you'll be taken straight to our training page. So this is the training page. The page is where all the online training modules can be accessed, and they'll change colour once they've been completed. So there are 11 content modules, and they can be completed in any order. Which will unlock after the introductory module's been completed. So for example, if you only wanted to do a module on treatment options, you're free to complete only module 8, or if you only wanted to upskill in identifying comorbidity and assessing risks, you're free to complete only modules 5 and 6. Your progress is tracked up the top there, and if you'd like to go through the key learning outcomes of a module before completing it, or your workplace asks what the training would cover, you can refer to the key learnings document there. So I'll just briefly walk you through one of our modules. So this person's completed the introductory module, which has then unlocked the others, and we're going to explore module 1, so what is comorbidity. So each module starts with a clear overview of what will be covered and the time the module will take to get through. So all modules vary in length, but if you were to complete the entire training program from start to finish, it would take about 10 hours. So the training is narrated, it's also user-friendly and easy to navigate through the navigation pane, so you can go back and forth between content as you need. And once you've viewed a slide, the corresponding bullet point will turn yellow, as seen here. So your progress is tracked up the top in the corner there, and as you move through the module, this will show you how much has been completed. And lastly, each module links to specific chapters from the guidelines if you want to refer back to the guidelines for more information about that subject. So each module has clearly identified key learning outcomes, which are assessed in a quiz at the end of each module following the introduction. So we've used different multimedia approaches and have incorporated case studies throughout the training. And this is, as I mentioned before, an example of relevant graphics supporting the text to help visualize information. So in collaboration with clinicians, consumers, academics and AOD workers, we also developed a series of short animations through Twisted Media in line with our multimedia approach. So this one gives a brief overview of comorbidity, and in other modules you'll find animations explaining some of the more common disorders that co-occur with substance use, like depression, anxiety and psychosis. So we've actually made these available to the general public as well through our Vimeo site. So in addition to the animations, we also use video examples of treatment methods in other modules. So this includes cognitive behavioural therapy and motivational interviewing. So we've had feedback from those undertaking the program that this is really helpful to see what these options actually look like in a clinical setting. So this module covers a similar introduction to comorbidity that we've provided in the presentation, just in a bit more depth. And each module will end with a summary of key learnings before moving on to the quiz. So I've zoomed out a little here so you can see the full quiz. So each module after the introduction features this 10-question quiz designed to test the key learnings. So these include a variety of question types, including multiple choice, tick all that apply, and fill in the blank questions, just to name a few. So we've covered the answers to not give anything away, but wrong answers will feature a link to the corresponding section of the guidelines for more information. And you can also do the quiz as many times as you like. There are no maximum attempts or lockout. And once all questions are answered correctly and the slides have been viewed, the module will be complete. And once all the modules are complete, as shown here, a link to download your certificate will appear. So this will list the number of hours, which depending on your registration provider, you can claim for CPD. So lastly, I'll briefly just share with you some preliminary results from the evaluation study we designed for the online training program. So initial analysis of the training program has returned some really positive results. So these figures come from 120 people who did a baseline survey, completed training and did a follow-up survey. So we found that 95% reported gaining skills that enabled them to respond to comorbidity more effectively. 94% reported they found the training useful or very useful. 94% reported greater confidence in responding to comorbidity. 88% said that they were using what they'd learnt in their clinical practice. And 59% reported that client outcomes had improved. So we still have data coming in, but these preliminary findings are really positive, and they do highlight the potential of e-learning as a really effective dissemination tool for comorbidity training within the AOD workforce. So before we finish, I just wanted to let everyone know that we're in the process of developing a more in-depth face-to-face training program based on the guidelines content. So I described the many benefits of online training earlier, but online training won't necessarily suit everyone or every service. So if you'd like to be notified when it's completed or find out more information, you can email us at inquiries@comorbidityguidelines.org.au. So that's it from me. Once again, our website is comorbidityguidelines.org.au. You can access a PDF copy of the guidelines or download that for free, build your own, or register for our free online training program. So thanks again for your time. We'll take questions now.
Thank you, Erin. Thanks for a very detailed presentation. Have we got any questions in the room? I have a couple online. No, I'm getting no hands up. So the first one is long, I apologise.
It's okay.
In regards to the various AOD usage, longevity and usage and mental distress, if the clients are exacerbating the situation through lack of help, self-medication, substances through time, are there methods for fast-tracking treatment options, or are we relying on family, friends, carers and loved ones to recognise the symptoms? I'm guessing that depends on where you're coming from. as to
Yeah.
what's related to.
Does that in terms of bringing them into treatment?
Yeah, I'm assuming
Yeah.
that's what it's asking.
Yeah. Not that I can comment on.
Yeah,
I don't
I would
think.
suggest that that's, as a ex-DDC, I would say that, largely rely obviously on family, friends and carers. But
Yeah.
it's also down to a good understanding of the NGOs and other services that are available in your area to be able to support clients through that.
Definitely.
The second question that we had come through, which is one that I was actually going to mention, I'll add the question on the end because there isn't actually a question, it's a statement. There's a significant link between ACEs, so adverse childhood experiences, with a score of 4 and above in developing mental health disorders and drug and alcohol disorders. I guess the question that I was going to ask, you talk about screening tools in the comorbidity guidelines. Is there any trauma screening tools
There are.
included?
Yes, so online on the website you'll find some screening tools for trauma-based things, I think there's quite a lot of good information in the guidelines about how to talk about trauma and sort of raise the aspect of trauma. Also in our face-to-face training program there's going to be a lot of good practical exercises for doing that as well, so when that does become available I'd recommend keeping an eye out for that as well. But yeah, that's right, there's a well-established link between childhood trauma and experiencing substance use and mental health issues.
And building on your response there, when you're saying about the face-to-face training, obviously that's being developed at the moment. We were talking earlier and you said that you travelled around presenting this. Is the face-to-face going to be based in Sydney that people travel to, or is it potentially something that will travel around?
At the moment we've got an initial workshop that will be happening in New South Wales, but beyond that I'm not too sure at the moment, so sorry.
I only have one other question, which is, you kind of mentioned a little bit and I'd just be interested to know, were consumers involved with the development of the guidelines, and if so, what role did they play?
Definitely. So we formed a panel of experts, and we had people with lived experience on those panels who were advising, the best ways to sort of talk about things in the guidelines and how to approach clients and things like that. And I think when you do read the language of the training program and the guidelines, that's pretty comes across to me. It's less clinical and more, irrespective of backgrounds, anyone can really read it and pick it up. And I would say it's a bit more humanistic in the way that it talks about approaching treatment and holistic. So.
Excellent. Any more questions in the room before I close? No, in which case, can you thank Erin Madden for an excellent presentation?